Odontogenic tumors. A tumor, by definition, is simply a swelling of the tissue. They are called so because they are manifested as swellings. Today, the term tumor is applied almost solely to neoplastic masses that may cause swellings on the body surface. So, the word tumor has come to mean neoplasm. And neoplasm, as defined by Willis, is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissues and persists in the same excessive manner, even after the cessation of the stimuli which evoke that change. In some more terms, the word benign is a Latin word, means mild, it remains localized and cannot spread to other sites and therefore generally amenable to local surgical removal. However, benign tumors can produce more than localized lumps causing serious disease. Example is an ameloblastoma. The word malignant is a Latin word again. It means bad kind, malicious, harmful, growing worse. Implies that it can invade and destroy adjacent structures and spread to distant sites, metastasize, to cause death. Metastasis is the movement of cancer cells from one part to another part of the body, secondary growth arising from primary growth in new locations, and it can spread by lymphatics and bloodstream. Malignant tumors are collectively referred to as cancers. We are going to deal with the benign odontogenic tumors. The classification of odontogenic tumors is essentially it comprises three broad categories. So we have ectodermal or epithelial odontogenic tumors, mixed odontogenic tumors, and mesodermal odontogenic tumors. So you see the ectodermal epithelial odontogenic tumor. Example, the ameloblastoma is otherwise called adamantinoma or adamantoblastoma or multilocular cyst. Ameloblastoma is a tumor that is usually unicentric, non-functional, intermittent in growth, anatomically benign and clinically persistent in nature. It is a true neoplasm of the enamel organ type tissue which does not undergo differentiation to the point of enamel formation. So it is the most common of odontogenic tumors, exhibit minimal inductive change in the connective tissue and represents with its varieties 1% of all tumors and cysts of the jaws. Incidence, it may occur at any age. Average age of discovery is 33 years. It has no sex preference. In Europeans and North Americans, over 70% of lesions involve the molar and the choroid region of the mandible. In Nigerians and Indians, the lesion may involve the anterior part of the mandible commonly. This is a varied origin. The source of the epithelium may be from cell rests of the enamel organ, remnants of dental lamina, Hedwig sheath, and epithelial rests of molasses. Odontogenic cystic epithelium, it is for certain that it comes from odontogenic cystic epithelium, dentigerous cyst and odontomas can cause that. Basal cells of the jaw, surface epithelium, in the case of peripheral extraosseous ameloblastoma, and pituitary gland epithelium, like in the case of pituitary ameloblastoma. So pituitary ameloblastoma is otherwise called craniopharyngioma or Rathke's pouch tumor, which is a neurosurgical problem. It's a neoplasm involving the central nervous system, but histologically similar to ameloblastoma of jaws and often destroys the pituitary gland and shows variability in its rate of growth. Clinical features may include endocrine disturbance, drowsiness, and toxic symptoms. So clinical features of primary extraosseous ameloblastoma occurs as a small nodule entirely within the soft tissue outside and overlying the alveolar bone and histologically resembles the typical central or intraosseous ameloblastoma. Characteristic features relatively innocuous, slow growing lesion, lacks persistent invasiveness of the intraosseous type and very limited tendency for recurrence. So excised locally with follow-up examination. So there is a typical central intraosseous ameloblastoma. It's a benign but locally invasive lesion, usually grows in all directions and destroys bone and invades the soft tissues. Lesions tend to expand the bone rather than perforate it, and the resorption of the roots is an extremely common finding. Most common symptoms, swellings may be 75% and pain 33%, draining sinuses 28% of the cases, and superficial ulcerations in 10% of cases would be very rare. So radiographic considerations of ameloblastoma. On the basis of the physical growth pattern, it is classified into 4 types. Multiloculated, multicystic type is the most frequent type. An unilocular type, and that present no characteristic features. The periphery is usually smooth in unilocular type. In advanced lesion, there is thinning of the cortical plate. segment is septate traviculated type and solid type of ameloblastoma. So the classic picture is a multilocular appearance, numerous well-defined cystic spaces of varying diameter. The tumor exhibits a compartmented appearance with septa of bony traviculae extending into the radiolucent tumor mass. The tumor grows within the medullary cavity, causing scalloping of the inner cortex by pressure erosion. Exhibit considerable sclerosis of the adjacent bone. You can see the radiographic features here. Multilocular, multicystic type, the most frequent type, a large lesion with a few straight septa in the lower ramus and body of the mandible is evident in the photograph. And then resected specimen showing curved septa, the second photograph. The unicystic ameloblastoma type present no characteristic feature. The periphery is usually smooth. In advanced lesion, there is a thinning of the cortical plate. Here you see the body and ramus is involved till sigmoid notch in condylar neck and root resorption in the case of 3-7, that is the lower left second molar, is evident. Resorption of roots of teeth is an extremely common finding in ameloblastoma. It could be detected even in an intraoral periapical radiograph. And in the occlusal view, you see the expansion of the lingual cortex with thin outer shell of bone, thinning of the outer shell of the bone. And biopsy is always necessary, must to confirm the diagnosis. The histopathologic features vary greatly. The major patterns are the follicular ameloblastoma and plexiform ameloblastoma. Others, acanthomatous type, the granular cell ameloblastoma, basal cell ameloblastoma, unicystic ameloblastoma, and plexiform unicystic ameloblastoma types are there. When considering possibility of malignancy in ameloblastoma, the diagnosis of malignancy depend on demonstrating metastatic lesions confirmed by histological examination. Lesion in lymph nodes and lung have occurred. The possibility of aspiration implantation cannot be denied. Malignant ameloblastoma, which has given evidence of truly malignant behavior, judged chiefly by the occurrence of metastasis, but in which the metastatic lesions have shown no significant histologic differences from the primary tumor. Ameloblastic carcinoma, in which there has obviously been an histological malignant transformation of the epithelial component, and in which the tumor behaved in a malignant fashion, so that the metastatic lesions do not resemble the primary tumor, but rather a well-differentiated squamous cell carcinoma, an epidermoid carcinoma, actually an epidermoid carcinoma. The ameloblastoma is sometimes discovered developing in the wall of an odontogenic cyst. Depending on the stage of development of the tumor, we have intraluminal ameloblastoma. The developing ameloblastoma is growing into the lumen and has not violated the wall of the cyst. Tumor is confined within the cyst. Conservative surgical approach is advocated. Mural ameloblastoma means it's growing in the wall of the cyst and confined within the limits of the wall of the cyst. Conservative surgical approach is advocated for that. And invasive ameloblastoma, the tumor is extended beyond the wall of the cyst and into the adjacent soft tissues. And when the neoplasm develops from the epithelium other than the odontogenic epithelium, unconfined lesion, a more radical surgical approach is required for that. And there is another variety of tumor called the same odontogenic tumor. We have a Pinberg tumor, which appears as an expansile, painless mass with an rather slow growth rate. Majority of reported cases were in the mandible, in the molar region, mostly associated with an unerupted or embedded tooth or teeth. Well, it also makes a radiolucent and radio-opaque lesion with an unerupted tooth associated. And we have odontomas, benign tumors of dental heart tissue. So they can be complex or compound odontomas. So composite, designates the presence of 4 dental tissues, enamel, dentin, cementum, and pulp. Occurs anywhere in the jaw with a predilection to third molar region, incisor canal region, and thank you.